पूछो जाके उनसे जिन पे रोशनी नहीं, पूछो जाके उनसे कैसी लगती है कमी।
Nikat Shradha this side. I welcome you all to the Optohub, a platform of learning, interaction, growing and growing. The barrier which hinders juniors and seniors interaction is easily being broken down by holding up the sessions which are very interactive. In today's session, you guys will get to know about why communication is important in optometry by SHRAVAN BAROT sir. He is a bachelor's in he is a BSc honors MC Optum who's graduated from City University of London. He is an optometry consultant at BAROT Eye Clinic and a marketing consultant and product lens vision center, Leeds, England. Thank you so much, sir, for accepting our invitation. I welcome you all to the Optohub. Thank you so much, sir. Over to you now. Please continue.
Perfect. So thanks for the introduction there. Thanks everyone for joining us as well. I'm going to be doing a talk in communication and why it's important in practice, just generally throughout with patients, with your colleagues, just in your daily life as well. So if I go to the next slide. What is communication? So there is a dictionary definition, which I've written on there: the imparting or exchanging of information by speaking, writing, or using some other medium. But simply put, it's transferring information from one place to another. Various ways of doing it. We do it all the time. You know, if we're speaking face to face, if we're communicating by phone, WhatsApp, even if we're watching TV, it's communication. It's communication of any art form. And that's what we're looking into today. Why is it important? When a patient comes in, they're coming in for an eye test, they've got their faith in you because of your skill set, your professional abilities. So they've already got that initial trust in you, but it's your job to build that rapport with them. Most of the time, these patients are coming in with problems. It's our job to resolve those problems. When we resolve those problems, we need to find that clarity, that direction. We need to give the patient management, we need to give them the advice. So by the time they leave that testing room, they have an idea exactly why they were having that problem to begin with, but they know now how it's going to be resolved through what we've communicated to them. And that creates better relationships. From a business standpoint, your main thing is patient loyalty. Give them a reason to come back. If you do a good job, if you communicate things so effectively that they can understand what you're saying, they don't feel rushed, they're going to come back. But in terms of other staff members as well, you want to increase your engagement with them. If you're running behind because you have an emergency patient, you need to let someone outside know so they can control that clinic for you, so there's no delay overall with the patients. Everyone's aware of what they're doing. But that improves the productivity and that can promote team building. You'll all work a lot better together when you've got good communication. Different types of communication. So I'm going to give you just the subheadings and then break them down and just show exactly how it all works in practice. Non-verbal. This is one of the most important things because this is the initial part. When the patient sees you, it's about the body language. It's about how you present yourself, how you carry yourself. I know wearing a mask, it's changing a lot of things, but you can still smile. They can still tell that you're smiling when you have a mask on. It's a very obvious thing and you'll notice it. When everyone's wearing a mask and someone smiles, you can tell. But be positive, be confident. They'll feel way more comfortable with you if you're that way, as opposed to if you're angry or just disengaged and not focusing on them. They'll notice that difference. Those subtle things can make a big impact. Mirror the patient's body language. It sounds simple, but a lot of people forget to do that. A lot of clinicians won't do it. They kind of just rush through the test, get through it, work 9 to 5. Enjoy it. You know, we have an opportunity where we get to meet 16, almost a minimum of 16 people a day. Every single day we meet 16 people. We can learn so many different things from each different person. That's the best part about this. What I normally do in terms of mirroring the patient's body language, when I do slit lamp examination, I bring the slit lamp away, I'll sit in front of them and just explain to them exactly what I found. Their eyes are healthy. I say, look, everything looks perfectly fine today. Your eyes are healthy, nothing to worry about. But I'll sit in front of them. It just makes them feel a bit more comfortable. Display open body language. I know different practices will have different setups of their rooms, but in the practice I've been working in, the computer's on this side, the patient sits on this side. Now, if I'm sitting here typing away, not looking at the patient, that's closed body language. They're going to think I'm not paying attention to anything they're saying when I'm just trying to write everything down. So take a minute, pause, leave the computer, look at the patient, face them, have a chat with them, and then that way they'll feel more comfortable. They'll feel a bit more open and able to tell you their different problems that they're having, and you can start looking into ways of finding the solutions. Lean forward when making certain points. Lean back when you're making other points. There's certain times to do it, and you'll kind of gauge that with experience. You'll know when to make these certain gestures. Use your hands, okay? Very simple. You've got two hands, use them. Head movements as well. Sometimes what I try and do is tilt my head a little bit, nod, sit back. Those subtle body language things will just help a patient feel more at ease in the testing chair, especially if they've got some serious problem, or if they're just apprehensive about coming in. This gives them that ease. It gives them that bit of comfort. Verbal. Everything you say, the patient's going to take, okay? It's all about how you talk to your patients, but also your colleagues. Be clear, be concise, and then they can understand exactly what you're trying to say. Understanding who you're talking to is also important, because that way you can adapt what you're saying. If you're talking to a patient, you want to keep things a bit simple. You want to make sure they can understand it without using too much technical terms. Whereas when you're talking to colleagues, if it's colleague in the practice, if it's hospital staff, communicate with them and be concise, because they've got their own time pressures in the same way that you will. That way you just gauge on your audience, you know who you're speaking to, and you can sort of dictate things in that sort of manner. Tone of voice, such a big difference. When you ask a patient how the day is, you can be, how's your day? If you're breaking bad news, you're not going to be in that same sort of mindset, same tonality. If you have to say to a patient that because of their vision they can't drive, you're not going to say, oh, you can't drive, because it's not a nice thing to say. With that, you want to be a bit softer. You want to explain, you want to take your time with it. Give them a second. Pause. Let them understand exactly what you've said. It's not about what you say, but the way you say it and the impression it leaves on the person who hears it. I think that's super important. It's not about what you say, but the way you say it and the impression it leaves on the person who hears it. I think that's really, really important. I think that's one of the key messages of verbal communication. Pacing. Slow down, okay? It's not a race. If you work from, you're just thinking, I just want to finish at 5 o'clock or whatever time it is, you're not going to have any enjoyment doing this in this profession. Take your time. You've got that patient in there for 20 minutes, 25 minutes, half an hour. Use that time. Patient will feel way more comfortable knowing that you're being so thorough, taking your time with them to explain all the different things, making sure they understand everything, allowing them to ask those questions if they're nervous, if they don't understand things. At the end of the day, we're providing a service. We're clinicians, but we're also given a service, and that goes back to patient loyalty again. If the patient feels rushed, they're not going to want to come back and see you, because they're going to think, this person doesn't have time for me. Take your time, slow down, explain everything you're going through. It just gives that better communication with the patient. They understand exactly what you're saying, what you're trying to go through. Now, obviously, with COVID happening, it's changing the way things are working everywhere in the world. Right now, we're wearing a mask, we're wearing gloves, we're wearing an apron, if we're wearing any other sort of PPE. It's making a difference in how we're communicating things. But even wearing all these things makes the patient feel a bit more at ease, knowing that everything is safe. Explain to the patient, I'm wiping everything down before you come in and after you leave. Make sure we do it for every single patient, so don't worry. Puts their mind at ease. While you're wearing a mask, it feels like everything becomes a lot quieter, especially when people are speaking to you. You kind of like, I didn't quite catch that. Can you say that again? When you've got the mask on, speak a bit louder. It's going to feel like you're shouting, but don't worry, you're not, okay? They just want to hear what you're saying. If you speak loud enough, enunciate, make sure you can take your time with it again. The patient will understand you loud and clear. Sometimes a patient may be hard of hearing. They may prefer you to wear just a visor or a face shield, because that way if they need to lip read, then they can do. So you've got those areas where you may have to change things around again, but we can still use the same techniques that I mentioned already. Your tonality, your pacing, that all can stay the same. Because you're wearing a mask, speak a bit louder. So, when it comes to communicating with colleagues, it's very, very different. Patient comes in, signs and symptoms of angle-closed glaucoma. They've got redness, pain, photophobia, halos around lights, Symptoms, you notice, you do all your checks, you see they've got narrow angles, high pressures, mid-dilated pupil. You're thinking, okay, angle closed glaucoma. You're going to call the hospital, write a letter to them. You can explain all your findings. It's going to be very different. It's going to be very clinical. However, to the patient, it's completely different. You don't want to show that, you're nervous or it's such a serious thing. You want to try and convey that seriousness, but in a calm manner. You want to take your time and be slow. Explain what you found. Explain why they're noticing these symptoms. Explain what this condition is called. Reassure them, tell them that, look, you came into this problem, but it's good that you came in today because we found a solution to it and we can start the management from here. What I'd say to a patient is, I'm going to refer you on to the eye clinic and they're going to go through everything in a bit more detail. Key thing is, you've come in and we found out today exactly what we need to do. And that way we can get the ball rolling and make sure this is managed. And by giving a patient a breakdown without using technical terms, they can understand exactly what's going on. They can understand the severity. They can understand the importance of what the management is. They need to go to eye casualty now. You need to reassure them and say, look, now's the best time to go. We don't want to leave any longer because that could have serious impacts, serious implications on your overall vision and the health of the eye. But reassuring them allows them to kind of understand what you're saying, take it in. And of course, they're going to be a bit nervous. They're going to be scared. But that's why you have to be empathetic. Take that time just to sit back and say, any questions? Do you have anything that you want to ask? And what I normally try and do is, if a patient has, they're not going to think of any questions at the time, but I'll say, look, I've put my name on your prescription. If you have any questions at all, give us a call and I can go through any queries that you have. And I think that makes a big difference because a lot of people won't do that. A lot of people won't put in the extra effort to say, any problems, give us a call and we can go through it with you. And that's reassuring because it means the patient feels they've got someone to go to if they're confused about what's happened. If you think about it, if you're a patient and you don't know anything about this and someone says you need to go to eye casualty, there's going to be a million questions running in your head, but you can't ask anything straight away. You may think of it later on. Give them that opportunity to call you back and go through things that they need to. Another condition, very, very common. Patients come with floaters all the time. You ask them, okay, so any flashing lights, anything floating around in the eyes? And they go, yeah, actually, I see this dot or line moving around. How long's that been there for? Oh, it's been there for a couple of days. I'm not sure what it is, and it's really bothering me. So you go through your checks. You dilate the eyes. You have a look for any tears, any holes, any breaks, any detached retinas, anything like a posterior vitreous detachment. Everything's clear. Now you need to explain to the patient what it is, but first you want to make sure if it is a detached retina that you're doing the right management. In your letter to the eye clinic, you're going to write everything that you found, including your signs and symptoms. You're going to write down everything there that you found today, and you're going to refer that patient to eye casualty. You give them a letter, call the eye clinic, speak to the on-call ophthalmologist, explain to them what you found. Very clinical. But when we go to the patient's version of communication, and if it's just a floater, you explain to them. And what I normally do is that we have a diagram, a little illustration on the wall of the eye. And I point to the vitreous and I say, do you see that blue area there? That's the vitreous, that's the jelly of the eye. That's made up of these collagen fibrils. Every now and again, one of these fibrils can separate. And that's what you're noticing as a floater. What you're noticing is essentially the shadow. And that's what I'm explaining to the patient because they don't know what this thing is. And I'll say to them, you may notice it more in bright lights, on a plain background, or if you're tired. They're probably the main areas that you notice. And it kind of clicks in this. Actually, yeah, I was looking to the sky and it's a bright sunny day and I saw it moving around. I said, that's your floater. Sometimes I'll even go into a bit more detail. I say, when you look to your left, there's always a slight delay and then your floater moves across. Because it's in the jelly, there's a bit more resistance. When you look up, the floater moves up and then slowly falls because of gravity. Same thing in the jelly of the eye. And then you want to reassure them that say, everything looks fine today. I've done the full thorough checkup, nothing to worry about. But give them the advice and say, if anything changes, you notice a very sudden onset of new floaters, any flashing lights, give us a call and come straight here. If it's out of hours, go to eye casualty. And I'll always say this, that it may not be anything serious, but if there is even a small chance that it could be something serious, I'd rather you take it as an absolute certainty and get yourself seen. And that way the patient doesn't feel panicked. They just feel more aware of that if things do potentially change. When you go through cataracts, if you're referring a patient to have a cataract done, different. Everything's clinical. You're writing down the type of cataract you're seeing. You're seeing nuclear sclerosis. You're going to grade it according to the grading scale. You're going to write that letter in. You're going to write down their vision, their VAs, any symptoms that they present with, any other conditions, any medications they're taking. That's all clinical. So that's what you're doing to your colleagues or colleagues at the practice or at the eye hospital. When it comes to patients, same thing. You need to figure out a way of breaking it down for them so they understand. And same thing what I said before, when I bring the slit lamp around and say, look, everything generally looks quite stable and healthy. But what I have noticed is a very early sign of a cataract. Patients instantly will go, oh, it's because I'm getting old. I'll say, no, it's because you're more experienced at life. They love that. And it makes it feel way better. But instead of calling them old, they prefer this way of saying it. Just a nice way to reassure them that, look, it's normal for this to happen. I'll explain to them that in the lens of the eye, it can slowly start to break down over time. And essentially, imagine condensation on a window, same sort of thing. But then I'll go into a bit more detail and I'll say, things like nighttime driving may start to feel a little bit more difficult than what they have been in the past. And a light bulb just flashes. The patient looks at me and goes, wait, yeah, how did you know that? And they look at me as if I've read their mind. All I've done is given them a symptom of a cataract. But to them, no one's mentioned that to them before. So they're thinking, wow, that's the reason why. I'll even say, even when it's, sorry, did someone ask a question? I'll carry on. And I'll say, even when you're reading in lower light levels, your vision may not feel as comfortable. If you go to a restaurant, the lights are quite dim, it can be a bit harder to see the menu. And they'll look at me again and think, wow, how did you do this? It's just simple explanations. We know the symptoms. We know what kind of things they're going to struggle with. Communicate that to them. Now they're aware of it. They'll know when things are changing. So when they come back to you again, they'll say, you know, I've noticed it's changing a little bit more. And you say, yeah, okay, we'll have a look into it today. And then we can manage it if necessary. The advice you're going to give, sun protection. That's where you go through all the options. UV damage can speed up the progression. What we can do, what I normally say to patients is, sun protection is something I'm definitely going to recommend because we can slow down the rate of change. We can't stop a cataract from changing completely, but we can slow down the rate at which it progresses. And then at that point, it's up to the patient in terms of what they want to do. But same thing, it's that reassurance that it's just gradually going to change. If you notice any sudden changes, give us a call. So now in practice, most people have a fundus camera now. Generally, so we take fundus photos on every patient that comes in. Now, a lot of people will take the fundus photo and won't explain it to the patient. They won't even show it to the patient. And I think that's such a waste of resources, such a waste of information, because patients want to know what that is. They want to see it. They want to understand what it all means. Explain what the different areas of the image are and what it's used for. You have all the different structures there. Go through it, the macula, the optic nerve, the blood vessels. Keep it simple. What I normally say to the patient, I'll show them, if this is the picture of their eye, I say, so this is the back of your right eye. Then I'll point to the macula and say, did you notice this dark area here? That's called the macula. That's in charge of the central part of your vision. What we're looking for there is any sign of fluid or pressure, and that can indicate macular degeneration. In your case, perfectly fine and healthy. Then I'll point to the nerve. Over here is the optic nerve. That's what gives all the information from the eyes to the brain. Same thing, we're looking for any sign of pressure or swelling, and that can indicate things like glaucoma. In your case, perfectly fine. I'll point to the blood vessels. Say we're looking for any signs of any systemic things, anything like diabetes, blood pressure, cholesterol. Depending on the patient, I may even go through it in a bit more detail. Say with diabetes, we're looking for sort of red splodges around the blood vessels. That can indicate diabetic changes. With blood pressure, we're looking for bendiness in the blood vessels, tortuosity. If you imagine a hose pipe with water running through it and you clamp one end, it's going to get very bendy because of the pressure. With cholesterol, we're looking for certain deposits scattered around the blood vessels again. But that's how I'd give them a breakdown. And I'll do the same thing with the other eye and just go through it again. And that way they understand what they're looking at. Because if you show them the picture and go, yeah, everything looks healthy, they don't know anything. They don't understand what you've just shown them. They just see a picture that looks strange to them. By explaining it, then saying, okay, that's why everything looks healthy. And same thing with more updated technology with the OCT, it's even better. It gives us even more information, but you can still keep it simple because now you can give them even more of a three-dimensional breakdown of what everything looks like. I don't go through each single tab of the OCT explaining each little thing. I'll go through the basics of it, and I'll show you that here. On the OCT, the NIDEC one that we use, if you click on the 3D image tab, you'll get these three images. And I'll go through the same thing again. So I'll point to the picture and say, this is the back of your right eye. Then I'll look at the bottom one and say, these are all the different layers that make up the eye. Then I'll point at the 3D map and say, this is a three-dimensional representation of these two images. Bit of a tongue twister. It took me a while to get that one right, but now that I've said it so many times, it's just second nature. Then I'll say, do you notice the dip just there? And I'll point at the macula on the layers. And they go, yeah. And I say, that dip is the macula. And then I'll go through it. It's in charge of your central vision. And what we're looking for is any sign of pressure or fluid. And I'll say if it was flat or raised, that could indicate fluid or pressure. And then I'll show them the nerve and say, do you notice this dip here? That correlates with the optic nerve, which gives you information from the eyes to the brain. What we're looking for there is any sign of pressure or fluid. A dip is a good, healthy sign. If there was any increase of pressure, instead of dipping down, everything would sort of bubble over because of the constant force of pressure. And then I'll do the same thing with the other eye. And that way they just know exactly what you're going through, and they feel like you've explained the eyes to them. When you go through, just slit lamp and say, yeah, everything's healthy, that's it. What have you told the patient? Nothing at all. This way they understand the health of their eye. They know why things look the way they do. So when they come again next time, they'll say to you and say, oh yeah, I actually remember that now. Yeah, that makes sense. Everything looks fine again. So explain things. And like I said, take your time with that. When you're doing an eye test of a child, it's easy to just be serious and be very professional. But you're speaking to a child. We've all been younger and we know we can get bored very easily. Speak to the kid. Otherwise, they don't want to speak to you otherwise. And you'll end up going round and round in circles and you'll get no answers, no clinical information. Give them positive reinforcement. We have stickers. Give them a sticker. If you need to do certain tests, you need to explain to the parent what you found. Do that. Explain to the parent, okay, this is what I found, this is what we need to do. Say to the child, you've done amazing. You've been absolutely brilliant. And here's a sticker. We're going to see you again in a year and you're going to ace it again. It just gives that positive reinforcement and they'll comply with what you're saying then. I've had times where, kids are just fighting me back when I'm trying to just do retinoscopy and they're just swinging their hands everywhere. You put a little picture up on the test chart and they're calm. You tell them you're going to give them a sticker if they do really well, they're calm. If you treat it like a game, they want to play. They want to get every single letter right. They want to see everything they can. It's just finding ways to adapt your situation. And like I said, while you're going through each test, tell the parent, okay, this is what I'm checking. I'm checking the muscles of the eyes. I'm checking their vision. I'm doing the health check. I'm looking at the optic nerve. The parent will just feel more comfortable knowing you're doing the full test to the child, but you're also giving them some reassurance saying that everything's okay, or if it isn't, giving them the management. So questioning, this is the next part of communication. When we do our history and symptoms, when we're asking any questions in general, it's the way that we ask that can impact the answers and the following discussions. Know the difference between open and closed questions. And it's very important. It sounds like it's nothing, but you start off with, how's your day? How are you today? Closed questions is when you start really channeling down their initial symptoms. They say, I've got floaters. How long have you had them for? Do you notice them all the time? Do they come and go? Things like that. It just gives you open and close at the right time. And it gives you much better answers in terms of defining what symptoms they're experiencing. That's how it relates directly into our profession. Anything that you write, referral letters, needs to be clear, needs to be concise. It needs to be straight to the point because hospital staff, they have their own time pressures. They don't want to be reading a novel. They want to read a referral letter that has all the information they need, and they can read, if they need to read the first and last line, they could get most of the information. That's what you want to have. You want to have a referral letter that's just clear and concise, not too long, not too much pointless detail, just all the relevant bits of information. When you're giving a patient any written information, which is normally a copy of their prescription, you want to give them exactly what you found for their glasses. When you're recommending they come back and sign it, but also put your name on there. Because like I said, if they need to call you, they want to they're unclear about anything, they know who you are and they can give you a call and ask for you directly so you can go through any queries that they have. It's important. All of this type of thing, written detail, is important. Explain the prescription to the patient. So many patients just don't understand any of the numbers that you give them. You print off a prescription, you sign it quickly, you give the prescription to the patient, they go upstairs, choose a pair of glasses, and they're gone. You don't see them for another 2 years. Take a second, when you've printed everything out, show them, this is what I found. And this is what I've started doing with all my patients now. I'll show them the sphere, cyl, and axis. So I'll say, this is the spherical power, and that correlates with the length of the eye. The cylinder, known as astigmatism, corrects the front surface of the eye. The axis is the direction that we're correcting. And I thought, oh, okay, that makes sense now. And I'll say with astigmatism, it's just a fancy word for distortion. And normally when I've got the dots on the screen, I'll get a -1 cyl and I'll rotate it around. And I'll say, do you notice how that distorts the image? And they'll say, oh, wow, I never knew that. So they understand now exactly what these numbers mean. Go through it with them to see where it's changed and how it's changed and how it affects their vision, why they've noticed these differences, but far away, even for close up. They'll understand it a lot better. And they appreciate that. So many patients will say, wow, I had no idea. Or, yeah, someone went through it with me, but they never kind of gave me the full breakdown of it. This way, when they come again next time, they understand what you're going through. And you can just give them that simple overview each time they come in. 2 years, they're going to forget most things that you've gone through in the eye test anyway. Okay. So, recording data. Oh, let me go back. Recording data and sharing it with relevant people. I know we're cutting off soon, so I'll try and get through a little bit more. In terms of options, discuss all the options. Okay, they've come in for an eye test. You found that they have a distance prescription and they have a reading prescription. They've got options. They can have separate pairs. They can have a bifocal. People who don't understand what that is, say it's the one with the line in the middle. It gives you your distance and your reading all in one. Or a varifocal. For patients doing a lot of screen work, say to them that a varifocal may be a better option because you get the intermediate part in that lens as well. Once you've given them the options, even if you're not doing the dispense, it makes the process so much smoother for the patient, the dispensing optician, and for yourself as well. And that way you're giving them all the right recommendations. If they're a -7, thin down the lenses. It's going to make the frame lighter. That when you look down, the frames don't fall off and break. It looks a lot nice. It's cosmetic. Discuss contact lenses. A lot of people just miss out contact lenses. Contact lenses can be for anyone and everyone. Give it as an option. They can have a think about it. We normally do free trials. So I say to them that if you want to try contact lenses, we offer it as a free trial. So you can give it a go. If you're happy with it, perfect. We continue forward from there. If not, you don't lose out on anything. Just going through the options, and that way they're aware of what's available for them. The last thing you want to do is tell them, yeah, you just need a new pair of glasses, and that's it. They won't know what the differences are. Patients who play golf, polarizing sunglasses makes a big difference. People who go sailing, fishing, polarizing sunglasses. Some patients like reactor light. They don't want to keep having a separate pair of sunglasses. Tell them reactor lights, transition lenses, all works. Just giving them the option, and that way they can make their decision based off of that. What I normally say is I'll go through some options and I'll say to the patient, I'm just going to give you sort of a brief overview of the options, but the dispensing team will go through it in a bit more detail with you. And that way they're already aware of kind of what they want to get. So when the dispensing optician says, yeah, so the optometrist discussed varifocal lenses, the patient will say, yeah, he did. Yeah, that's exactly what I want to go through. And they can go through that. Okay, I think the session is going to stop in less feels. Put their fear at ease, reassure them. And that way they're going to understand, okay, this is all it is. And I always say to my patient that the main advice I always have to give with contact lenses is don't fall asleep in them because they're that comfortable. Patients who play sports, contact lenses. Varifocal contact lenses are great, they're perfect. Fit more people with varifocal lenses, they're going to appreciate it. And like I said, we do it as a free trial, so no one has to commit to anything until they're happy with it. So eliminate their fear. But that was my last slide, so hopefully I've done it in time. And then I'll rejoin if there's any questions that anyone wants to ask. But that's everything from my side of things.